We're going to go straight now to an interview with Professor Bob Wachter of the University of California, who is a bit of a legend in many ways, not only because of his chair of Department of Medicine at the University of California at San Francisco, but also because he chaired the Wachter report on IT for the NHS, which was published in 2016, which had a major influence on NHS digital strategy. Most important position of all, he's chair of this institute's scientific advisory board. And throughout the pandemic, he's accrued an extraordinary social media following. And the other thing you need to know about him, and he's just told me this now, he is possibly the biggest fan of Bruce Springsteen there is, or at least, as he said, in the top 10. And I'm going to pass you over now to Jenny Burt, who is going to interview him.
I'm Jenny Burt, Senior Social Scientist at this institute, and I'm absolutely delighted today to be talking to Professor Bob Wachter. So Bob is Professor and Chair of the Department of Medicine at University of California, San Francisco, UCSF. He's very much regarded as a leading thinker in the role of hospitalist medicine, having coined the term hospitalist, actually, in a New England Journal of Medicine paper back in 1996. Bob's written extensively on patient safety and digital health technologies, including a New York Times Science bestselling book, The Digital Doctor, which is very much worth a read. And of great relevance as well for us here today, Bob is currently chair of the Scientific Advisory Board at this institute. Bob, welcome to this space.
Thank you, Jenny. It's a great pleasure to be here.
So in 2016, Bob, at the request of the UK government, you led a review of digitising secondary care and using IT to improve the NHS. And that culminated in a report called Making IT Work. And during that review, you were looking at what worked and why in IT and healthcare, and also where improvements were needed. So thinking back about what you learned about the NHS during that time, what could you predict would have worked and what wouldn't, as the NHS was suddenly faced with responding to the COVID pandemic?
Well, first of all, I learned how impressive the NHS is and how many spectacular people there are working in it. I also learned that it's pretty bureaucratic, and one of my concerns would have been how nimble it is, in that there are massive advantages to having your health system largely run by the government, but also real challenges, particularly in areas that are rapidly moving and are depend on innovation. The core advantage, I think, of having the NHS as a essentially single system, and I know every time I say that, people say, well, yes, I know, but it feels a little bit siloed, and of course it does. But at least the potential and aspiration that it acts as a single system is the ability to disseminate information out there quickly, to organize studies across the entire ecosystem. And in fact, that has played out. If you think about the literature base that we use to make decisions in COVID, a disproportionate amount of it comes from UK clinical research. And if you think about the number of patients and people in the UK, it's clearly punching above its weight, as we would say in the States. I'm not sure if that translates in terms of its impact on clinical research. And if you think about the work in vaccines, for example, the UK has done very impressive work throughout COVID. But in terms of the digital background, you have a real advantage having a single system that is that at least theoretically is woven together digitally, where you can collect data across the entire system, analyze it, look for real world evidence, and then implement either intentional trials of doing this versus doing that, or look at natural experiments, see what happens to have changed for a variety of reasons, and look, I think, at a much more easily than we can in the US, where we really have a patchwork system at whether something worked.
So thinking about that US experience, what kind of resilience do you think there was and is in the US system, again, to be responding to these major challenges?
The US, at this point at least, has failed in its COVID response, and really at a massive and almost unprecedented scale. And much of that just happens to have to do with our politics of the moment, which is extraordinarily fragmented and partisanized. And COVID is a societal stress test. I mean, it really is it entered into the society. Probably not true. It's not just COVID. Any pandemic comes in and tests the resiliency of all of your institutions. It tests the relationship between the people and the government, between the government and industry, and requires all sorts of things that are just turn out to be hard. Rapid mobilization of the healthcare system, of the public health system, of the scientific community, rapid engagement of the people in a way that scares them appropriately, but doesn't scare them unduly, but scares them enough to give them realistic information about what they need to do and the sacrifices they may need to make, gets them to be ready for the long haul, that this is not going to take a month, it's going to take a year or more. And so that's, and I think, we hearken back to Churchill and how that can be done well. And then we look at the US, and that this will be a textbook example of how that can be done poorly.
So one of the things that you've done during the COVID pandemic is become a voice of information. You're quite active on Twitter. For those of you who use Twitter, you have quite a large number of followers, and I see it's going up on a week-by-week basis at the moment. Yes. But you've been doing a series of COVID Chronicle tweets, which are sort of updates both on COVID cases and treatment at US CF, but also how the pandemic's been spreading across the US. And of course, one of the major points of debate has been around the evidence base for COVID treatments, and you've also run a series of kind of ground rounds and YouTube discussions around how your experts are responding. Now, obviously, people are aware there's a whole spectrum of views around how doctors could and should be treating this novel virus. And I really wanted to know what you think can or should count as the right evidence in these kind of situations.
In terms of the evidence base and the necessity for evidence in a public health emergency, it's kind of interesting because you have to say, what is the threshold for action? And if you're talking about therapeutics, if you're talking about drugs or a vaccine, it probably is no different than normal in terms of we want to be really sure, statistically sure that this thing really works and is really safe. And therein lies attention because you have no other situation I can think of where those kinds of decisions are also of tremendous political importance. Everybody is watching, everybody cares, either because you are sick, you might get sick, or how we're doing in COVID has a massive influence on whether you can get your life back to normal, whether you can go and get your hair cut, whether your kids can go to school. All of those things hinge on some reading of the evidence. So it's being scrutinized by everyone. And you can argue that the stakes are so high that you might loosen some of the restrictions in terms of evidence in a way that this maybe sounds paradoxical, in a way that is somewhat evidence-based, meaning put into your hopper as you're trying to weigh everything, the fact that delay actually has a consequence. A delay means that the economy is going to be shut down for another month. How does that influence things? On the other hand, for vaccines, you might say, well, we've got to go as fast as we can. But if you approve a vaccine and then a month or two later, it turns out there's an unforeseen side effect and everyone loses faith in it, that there's an area where the public trust is so important. So it's really important not to lose the public trust. The speed needs to go much faster than the usual. There are other areas where, trying to slavishly stick with P is less than 0.05 just is not realistic just because of the nature of clinical research. And so masking is a perfect example. Mm-hmm. A essentially completely benign intervention that we will never have a randomized controlled trial for. At some point, it became clear enough from natural experiments and from theoretical experiments or physics experiments that the odds were very good that they worked at essentially no cost and no harm. And people who were saying, well, show me a randomized controlled trial, were basically making a political statement. They were saying, I don't like masks because my team in the US masks sort of parsed along. If you were a Democrat, you liked them, and if you were a Republican, you didn't. And it really became, well, my team doesn't like them, and therefore I'm going to insist on a higher level of evidence. So one more point that's been fascinating is I can't think of a time in the history of science in my lifetime where there has been such intense public interest in the science, because we all have a stake in it, and the public has been watching science play out in real time, sometimes in ways that are really quite gratifying and fun. So, for example, as you mentioned, we host a weekly Grand Rounds, which is 4 scientific experts, often talking about different topics, some quite scientific, virology, epidemiology, and 50,000, 100,000 people will watch it later on YouTube. My best friend, who's a stockbroker, who had no idea what I did for a living until 6 months ago, emails me the day after and said, bring back George, who's our main epidemiologist. I want to hear more from George. The fact that lay people are watching this, and so that's exciting. That's wonderful. The public is much more engaged in science than I think they ever were. On the other hand, they don't know how to interpret it, and particularly the zigs and zags. So, well, you said last week this, and now you say this week that. Can't you people get your act together? As opposed to, that's called iterative science. We learn as we go on. The question, I think, in terms of clinical care, I think has been terrific. If you think about it, I don't know how it is in the UK now, but in the US, it's pretty clear what works and what doesn't work. I mean, the standard.
You've seen the consensus move.
Yeah, consensus, and it evolved very quickly. The studies came out, and they don't wait 3 months for a journal. They come out in 5 minutes. They get published eventually in Lancet or the New England Journal, and everybody looks and says, okay, the standard of care for this kind of treat COVID is remdesivir and dexamethasone and monoclonal antibodies, promising, not quite ready yet. I think there's really, I can't think of a case where there's such rapid dissemination of information and such rapid consensus building about the right thing to do.
So at this institute, obviously, our major focus is not these medical treatments or, for example, surgical procedures, but very much the services and systems within which these things are embedded. So always here, the debate on the generation of use of evidence can get really quite complicated, because we're suddenly dealing with how people interact and how equipment interacts with people and all of these much more complex systems. And in the light of COVID, those systems suddenly had major rapid changes. And there's loads of different things I want to speak to you around this kind of area. And again, just following the thread of what is good enough evidence. But in times of major emergency responses, when we're talking about things like service changes, which are just being forced, should we even be worrying about good enough evidence? What's your view? What should we be doing to try and drive any kind of change through some kind of evidence?
Yeah. Well, one of the things I found fascinating in my institution was the command center approach. That when the pandemic first hit, and just thinking about late February, early March, we quickly shifted to a command center structure. And
is this at UCSF? At
UCSF, my institution, which is a huge academic medical center in San Francisco. And what it really was a healthcare version of martial law. It basically said, we are, we have 100, I run a huge department. I have 3,000 people that work in my department. I've got a lot of control and a lot of power, and I've got a decent budget, and pretty important, it's sort of decision making. The reason I started tweeting was I felt completely impotent. I had nothing to do. I was on Zoom meetings all day long taking in information, but I had no decisions to make because all of the decision-making authority had been taken away from all of the departments because we didn't have time for all the usual stuff. The meetings and the consensus. There's an old saying in American medicine, I don't know if it translates into British, what do you call a 99-to-1 vote of the medical staff? And the answer is a tie. That
I can see what that is going. Yeah.
I mean, everybody's got to agree. Well, there was no time for that. We were standing on the beach, and we knew there was a tsunami coming, and so and there really wasn't. We used the best evidence that we could, and sometimes that was because there was real evidence. Sometimes that was because history told us this. I mean, we all went back and read books about the 1917, influenza pandemic. What happened then? What was the experience during swine flu? All of that. What did we learn from other similar emergencies? And so in some circumstances, and this was one of them, we just did not have time to wait for the usual evidence. And in that way, I think it felt more like a traditional business. When I talk to CEOs of big businesses, they sort of can't believe this P is 0.05 and wait for the journal article to come out. They manage from the gut. They try to get the best evidence that they can. And a lot of that is expert opinion. And then they make the best decision they can. And then they have very hard metrics that they're following. And they're willing to say, that didn't work. Let's try something different. It's hard to argue that wasn't the right call. I think in healthcare, because the stakes are so high, it then becomes very important to mine what you have done as a natural experiment or a series of natural experiments to try to see whether you can actually learn iteratively and get better, both within an individual institution, but across an entire sector. And I think
have you done that, for example, at UCSF? Because everyone is so consumed with making these changes and moving to a command center. Is there also people alongside saying, and it's okay, we've designed some studies to look at that, or did that fall by the wayside?
I think it mostly fell by the wayside, not intentionally, but because unfortunately it becomes a lower priority. When you are so busy acting, the idea of putting in the resources and the time and the energy to analyze things in the most rigorous way, it tends not to be the highest priority. But I think it actually did, in a place like mine or yours, where the sensibility is scientific, where that's the way people think. I think there's a natural inclination to do that. Well, we set up this clinic and organized it this way, and we surveyed the patients, or we measured the throughput, and it actually didn't work as well as this other clinic that we set up this other way, not because we were thinking about a randomized trial, but the resources and just the opportunity meant we were going to do it two different ways. And it seems like, or maybe even there's a little bit of data that shows that way B worked better than way A. Let's do more of B and less of A. So I think there was some of that happened. I do think that in terms of data, and this sort of gets back to the UK's structural advantage as a single system, one of the things that has happened that's been really magnificent is the creation of dashboards. And I think it will be one enduring impact of COVID. I every morning get up and look at about 10 different websites to show disease trends and epidemiology and which states it's breaking out. And then I can go into UCSF's website and see basically everything I want to know. How many COVID patients there are, where they are, how they're doing, how many surgical cases do we have, and in a way that is real time, set up in a modern data visualization kind of googly way that is attractive and interesting and easy to use without having to know how to write code. I think that's been something that has been something that came out during COVID, because there was such an intense need for decision makers to have real-time information about how things were doing. And I think that has gone into that's become part of the evidence base. Maybe not in the formal way, we're not studying it, but I'm getting lots of sources of data that are being refreshed real time and presented in a useful way. I think that's been a real advance.
But what we're talking about here is pretty much the response of services to the onslaught of COVID cases. And obviously, as people are increasingly intensely aware, that meant a lot of other things just stopped. So, for example, you talk about dashboards in the NHS. A lot of audit data was just stopped. So we're now missing, we're going to be missing a whole year of really important data sets. And we also just overnight stopped a whole range of really crucial activities. So, for example, quality standards inspections. So within the NHS, the Care Quality Commission just stopped all of its regulatory inspections in the middle of March. They're restarting slowly in the middle of October in a very different form. And again, that's just another natural experiment going on here, where services just stopped. And again, what kind of learning should we have from this when we're thinking about when to restart services and how to restart services?
Yeah, of course, it's going to be hard to interpret those natural experiments because they're confounded by this little thing called COVID.
Exactly.
And so, if the budget had run out one year and you stopped the inspections, that would be an interesting experiment. This will be, as you know,
but let's put a pandemic on top of it.
Yes, let's put a pandemic on top of it. See, and let's do we'll do a regression analysis. We'll adjust for COVID. I think that's a challenging thing to do, but of course, there may be some things you learn from it. All of the infrastructure and the inspections and the regulatory structure is an intervention, as you well know. You study it, and it's got costs and benefits, and the decision to suspend it. You have to believe structure itself has some benefit, one hopes, and suspending it comes at a cost, probably. It may have benefits also. I mean, the regulatory state takes on a life of its own and can often become overexuberant and cause its own harm, which of course is the source of much of the right versus left debate in the United States, and probably true in the UK too. So, it may be that you suspend it and lo and behold, things are fine and everybody's, more innovative and getting their work done better. And you begin to think about, do we need as much regulation as we have, accreted over the years? That I think one should stay open to that hypothesis. But, in a pandemic, the idea of suspending some of the regulatory apparatus because it's either not safe to do, or we can't afford it. I mean, it's a reasonable decision, and I think it's actually quite smart of this and for you to mine all of the perturbations in the system to see what we can learn from it. But it will be challenging to adjust for
COVID,
the elephant in the room, which is why they were suspended in the first place.
So thinking about other overnight switches as well, and we had a chat about this before we started recording, but telemedicine. So, for example, again, in the NHS, there'd been a tiny little, sort of minority slogging away, trying to look at GPs doing video consultations and so on and so forth. Lots of research in various specialties about telemedicine and telemonitoring and so on and so forth. And again, overnight, suddenly, everyone's doing telemedicine absolutely everywhere. And I'm sure you've got quite a lot of thoughts about what that means, particularly for digital healthcare.
Yes, I think that will be the most enduring change of sort of innovation in the healthcare system that comes out of COVID. Alternatively, I've been a sort of student of artificial intelligence, and I wondered whether that would hit its tipping point, and it clearly hasn't. I really can't think of very many things in AI that now we do them after COVID and we didn't do them before, which says it just wasn't there in its hype cycle to reach the pinnacle of utility. But telemedicine clearly was. I mean, it was at a point where the technical capabilities were there, but at least in the US, the obstacles related to the regulatory environment, the payment environment, and the change management and cultural environment on both sides. Patients not sort of understanding it and being willing to do it and not really saying, why should I? I can just go see the doctor. And doctors also feeling like it's new and I don't really understand it and I haven't worked out all the workflows, which is a huge deal. So there was enough inertia plus regulatory plus payment that it just wasn't happening on its own. When I started as chair 5 years ago, I'm a fan of it, and I have to say I'm slightly conflicted now because I'm an advisor to a big company called Teladoc, which is an international telemedicine company. So, but I even before that, I was a fan of it, and I think it makes all the sense in the world. We were doing 1% of our ambulatory visits with telemedicine. And so for a few years, I was pushing it really hard. I put in incentives to try to do more of it. And just to show you my immense power, we got from 1% to 2% in
congratulations.
Over 3 years. I felt very good about that.
Yeah.
Once COVID hit, we went from 2% to 70%. It took about 6 weeks. Yeah. So just to show you how change can happen. And I think it's durable. Now, part of it was the regulatory barriers fell in the same way that you say the inspections fell, but this was quite intentional. The regulatory barriers went away. The payment got better, so that it was almost equivalent to an office visit. And then the reason I think it will be a tipping point is both the patients and the clinicians tried it. And they all said, I like it fine. The clinicians like it fine. The patients actually like it better. Our surveys show that patients prefer a televisit to a real visit.
Interesting. Ours are mixed experiences. We've done a lot of work on the overnight switch and mixed from patients' views.
It's for us, the patient, and me, this is at UCSF, but I think we're seeing it nationally. At UCSF, it's partly because, driving in and paying the bridge toll and then parking and spending $30 to sit there, and the doctor's an hour late and then sees me for 15 minutes. And it's like, you mean I can do this sitting in my living room? And the doctor pops on. So there's a lot of things to commend it. I don't think it's not staying at 70%. It's already down to about 25%, but I think it will be an enduring part of the health system. So it requires, as you're already doing, it requires a lot of research to understand how to make it work. There's a lot of different ways of doing it. I think that the biggest issue in telemedicine, which has been underemphasized, is that if all telemedicine is a visit replacement. I'm now, the 15-minute visit with the doctor that I used to have every 3 months for my blood pressure or my emphysema is now a 15-minute televisit. That's fine. It's a little interesting. What is the role of the physical examination? All those sort of things need to be studied. How do I establish rapport through the video rather than in person? But that's fine. The real, the enduring issue, and this has a huge impact on research, is if I'm not coming into the doctor's office anymore, and that's not the point where I get my blood pressure, my breathing, my glucose checked, now it really forces those pieces of data have to come from digital data flows that are going to be checked on me at home. And if that's how the data are coming, now why should it be once every 3 months? If I'm checking my blood pressure digitally every day or twice a day, or my sugar 4 times a day, well,
all of it.
I want all of it. It's going to flow into the system. So we have, people in the US sometimes talk about that and say, that's wonderful because every GP is now going to be getting all of these data on all of their 2,000 patients, and think how happy they'll be.
Oh, they'll be so
and I
happy.
Immediately, that is a universe that I am not familiar with, because if I said that to my GPs, they would quit by 5 o'clock this afternoon. So it creates the need for a whole new layer of the system that I sometimes call care traffic controllers instead of air traffic controllers, who are taking in the data, monitoring it, mining it. Some of that has to be AI. That cannot be all human people. Triaging it. Well, this person needs a health coach to come on. This person actually needs to see the GP. This person needs to see the specialist. There needs to be effector arms that, some information gets back to the patient. You need to increase your insulin or decrease your salt or whatever. It's massively complex. I don't think any of us have even begun to think about how to do that. And it also means all of those data are going to be flowing to the system. Well, they also can flow to researchers who can mine those data, along with, over time, other sources of data that relate to social determinants and your Twitter feed and your, all the sort of thing. All it raises all sorts of privacy issues as well. But the ability to now have a very large and much more robust and rounded data set that has to flow into the healthcare system in order for care to be delivered. Health services researchers should be able to stick a plug into that data stream, take it, and learn much, much more about patients and patient care and healthcare organization than what they've been able to do before, when the visits were episodic and in person.
Are we possibly talking about innovations, though, that are going to widen inequalities with these digital innovations?
Yeah, it certainly is possible that will happen, and it's equally possible that the opposite will happen. Mm-hmm. As soon as you say it's digital, and I think about the digital divide, that I was able to stay home the last 6 months and do my Zoom meetings and not get too bored because I had Netflix. And, many people had none of those things, and they had to go out and work in the grocery store, and they were the ones who got infected. Of course, it's logical to say that anything that depends on digital creates the opportunity that it will widen disparities. That's a legitimate concern. On the other hand, the digital tools that we're talking about are not that expensive these days. The disparities that are born of the existing system, because people live too far away from the doctor or the specialist or the hospital, or don't have ways of learning about how to take care of themselves in a way that's presented to them so that it's accessible to them in the language they understand at the education level that's appropriate to them, that can understand their preferences. All of that should be better in a more digitally enabled environment. It won't necessarily be better, but I think if I was a betting person, I would say in a smart, well-organized health system that is at risk for the cost of care, and therefore potentially will say, we're going to make an investment in being sure people have access to these tools because we think we will save enough money on the back end from fewer hospitalizations and emergency visits. I would think that the odds are that this should decrease disparities rather than increase disparities, although it could go either way, which is why it's a subject highly worthy of study.
We've already touched on this, but the idea about the different voices that we're now seeing within the healthcare ecosystem, and particularly from your perspective, because you've done a lot of thinking around this, around how change happens and what the drivers for change are. I think for a lot of people, it might feel at the moment, and we mentioned how chaotic it can feel with all of these different voices, researchers, clinicians, pundits, the public, all suddenly becoming experts, all suddenly having opinions, all being quite upset at times. It's quite a challenging space to have a debate at the moment, I think. How do you think change is going to happen effectively going forward? And of course, crucially, where's evidence in that? You know, how are we going to bring evidence to the table in this situation?
In the United States, one of the most upsetting things about the current political environment, and I think COVID's brought it out to some extent, is the questioning of expertise. And I say that, and even as I say it, of course, expertise should be questioned. It's not chiseled into a tablet that everything the expert says is right, and therefore we should genuflect to it. The scientific method does question expertise. That's part of what's magnificent about it. But the devaluing of expertise, and the almost, you're an expert, then you're an elitist egghead, and I'm not going to listen to you because you can't understand my lived experience because I didn't go to college. It really has become so balkanized and so dichotomized. And of course, that's ridiculous. I mean, experts know stuff that the rest of us don't know, and we need to take advantage of that, not in an unquestioned way, but in a way that's rational.
Sure.
On the other hand, one of the things that has happened, I don't know that COVID has been particularly crucial in this. I think it's been a trend that's been happening for years, is a recognition that there are different kinds of expertise. And the expertise of the physician or the scientist or the researcher is really important. And the expertise of the patient or the family member is also really important, and is different than, and often quite different than, that of the sort of more traditional expert. And that the healthy system will weave all of that together in ways that are useful and healthy and advance the agenda. And the trick there is having all of these parties recognize their shared interest and the importance of creating a learning community that will help us get smarter, faster, and do the right thing. That's part of what's so upsetting about the polarization, because it sets up these as mutually exclusive sets. It's either the person and the experts are elitists and they don't know anything, or it's the elitists and the experts and they don't think patients. I mean, that's all ridiculous. It's all important. It's all has to be woven together. There's something really important about valuing the roles of patients and families and carers in this, but not seeing that as a tension between these different parties, but seeing that as a communal effort to come together and take advantage of everyone's expertise and everyone's skills, and then studying in ways that are useful. And certainly easier to study a cell, under a microscope than it is to study a community, or look at disparities. But it's really important. It's up to us as scientists to figure out how do you do those studies in ways that are feasible and really advance our knowledge.
Which is a fantastic summary of what this Institute community is trying to do. Absolutely weaving, as you said, all of those voices together, and valuing the different expertise that's brought on all sides.
Yeah, I have to say that, one of the things that's been gratifying about getting to know this institute and what it does, the emphasis on that work and not just lip service. I mean, you hear a lot of lip service about this. It's an easy thing to, it's sort of politically correct to say, oh, we need the voices of patients, but to say it's important and we're going to build tools and platforms and mechanisms to gather it in a meaningful, scientifically rigorous way and use it in the way we understand these processes. I think that's magnificent. And I think the Institute has become a world leader in that.
Thank you so much for your time today, Bob. It's been fantastic talking to you. And we look forward to working with you at this institute over the next few years.
Yes, I do as well. And I'm hoping that we can work together in person eventually. It's a great joy. And the work you're doing is really inspiring. Keep it up.
Well, thank you so much, Jenny, and thank you, Bob. And can I just say a couple of numbers here? Actually, his Twitter following now, as I just looked, 153,400. So that's a pretty impressive, I would say, tribute to your wisdom. And actually, we've enjoyed hearing that too. The second number I want to tell you about is that we've had nearly 500 people on this event today. So that's terrific. And I'm sure a lot more will be watching later on demand. There are some questions here. And one of the really interesting one, and you touched on it in your conversation with Jenny, it seems that the public have been exposed to the politics of healthcare and the reality, warts and all, of the scientific process in an unprecedented way. What do you think the impact of this will be on trust in public health and science?
I think some of it depends on the vaccine and the way the vaccines roll out, because I think in the end people will mostly remember that. They will airbrush some of the more uncomfortable stories here about masks, about the conspiracy theories, about hydroxychloroquine, and I think they will remember the role of epidemiology in helping us understand this, and they will remember the role of science in creating vaccines that ultimately will have saved the world. And so we're seeing increased interest in science. We're seeing increased applications to schools of public health. I hope we don't forget some of the bad stuff here, because we really did screw this up in all sorts of ways. And the importance of public communication, the importance of trust, the importance of gaining a consensus, at least in the U.S., and my impression is in the U.K. as well. We did this really poorly, and I'm hoping that this will help us do better the next time.
I think something that everyone can agree with. We have not covered ourselves in glory here. There was another question from Graham Martin, which I thought was an interesting one. Building on some of the themes from earlier in the day, is there a risk that changes made in a rush of necessity based on gut instinct, but without time for evaluation, become stuck? How do we ensure that they get evaluated after they've been implemented? Or has the horse already bolted?
Well, it may feel different over there, but in the US at least, I don't see that many changes that are kind of big fundamental remodels of the system that are likely to get stuck. As I said in the interview, telemedicine is probably the big one. And I think it had an artificial peak and now is achieving sort of a middle ground where I think we'll take a more measured look at its appropriateness, where it fits into the ecosystem. Other kind of rapid changes feel very pandemic specific. I don't think we're all going to be wearing masks 5 years from now. I don't think the schools are going to be closed. I'm hoping. I think the one maybe that might be the most interesting in terms of sort of taking a good hard look at change and whether and not just accepting it is the way we disseminate information. So we have moved to a model for information dissemination of via press release, via non-peer-reviewed preprint, with peer review occurring mostly in Twitter. That has been entirely appropriate for a pandemic because information needed to get out quickly, and it does feel like it's a democratization of the peer review process. So to me, it's worked reasonably well, but when the dust settles, we really are going to have to think hard about that. Are we going now? Have we tilted to going too fast And is there too much risk that we're going to be putting information out there that is insufficiently vetted? But beyond that, the other trends that I've seen, the interest in health disparities, I think is a positive trend that will come out of the pandemic. What to me is extraordinary, people look at, oh my God, look at the differences in COVID rates depending on if you're Black or Latinx compared to if you're white, and your zip code, as Kaveh was talking about. But as Kaveh mentioned, we've known this for 100 years. It feels like the scene in Casablanca where we're shocked by learning of health disparities. My God, we've known this forever. The question is whether the visibility it had during COVID and the passion and its intermingling with the other racial issues that came to the fore, at least in the United States, will lead to more concerted and successful efforts to address them. I have to say, in the U.S., I'm skeptical about that. And the reason is, as I think Kaveh said, we're talking about resources. If you want to address health disparities in the U.S., we spend 20% of our GDP on healthcare, $4 trillion a year. You would take money out of the acute care system and you would move it into housing or the educational system or the justice system. Well, I can tell you that every vested interest in the healthcare system, including my own, including academic medical centers, will fight that like hell. I mean, they will say, on the one hand, of course, we want to address health disparities, but as soon as somebody says, okay, we're going to cut your budget so that we can give more money to the educational sector or to the justice sector, they will say, oh, no, that's not where it needs to come from. We need it. We're doing God's work here. So I think it's a very knotty problem to the extent that it actually requires real redistribution of resources, whether it's raising taxes or whether it's moving from one sector to another. In the US, the healthcare sector is very, very good at garnering resources and very good at preventing anyone from taking it away. And I think that will be a limiting factor here.
I mean, there has been a triumph of science, whether it's vaccines, whether it's looking at the drugs, whether it's the kind of trials that we've seen, like the recovery trial, solidarity trial. Was there anything from reviewing historical pandemics and what worked that we could have acted on more quickly in the current crisis?
We could have learned from the 1918 flu pandemic that there would be an anti-mask group that would emerge, that there would be this tension between sort of the dichotomization of people who were for public health and the other people who were for the economy. And in the US, that it would be layered on top of a very strong libertarian streak, which is, who are you, government, to tell me what to do, and the nanny state and all that. There's some of that in the UK as well. I think we should have understood the politics of that better. And if we had more rational leadership, we would have been on top of that. And I don't know, it's not necessarily that we could have done anything to prevent some of it. Some of it's invariable, or it's going to happen. There's no way you can get around it. But I think a rational government and a rational public health structure would have anticipated it, would have thought very hard about messaging, would have thought about the role of influencers in terms of masks in particular. Having the government, I mean, in the US, we had the president saying, I don't believe in masks, but even if you had a more rational, less crazy leadership structure, I'm not sure the president saying it is the key thing. It's, as you said, I'm a Bruce Springsteen fan. It's Bruce Springsteen saying you should wear a mask, or whoever a 25-year-old listens to. Try and understand that the pathway to getting people to change behavior is probably through Instagram rather than through more traditional political channels. I don't think we understood that very well and didn't use sort of all the tools that we need to use to get people to change behavior. We know how hard that is. A lot of the early part of this was behavioral change. We just got that wrong. We underemphasized it, and then the political thing just mucked it up. On the scientific side, I think it's been magnificent. I mean, I find it very hard to quibble with, a brand new virus that we didn't know about on January 1st of this year, coming up with trials convincingly demonstrating which therapies work and which don't in 3 or 4 months, and coming up with vaccines, highly effective vaccines, in 10 months. I can't imagine, if you back out the time it takes to develop it and then trial it in tens of thousands of people, there's no room there to make it all that much shorter. Next time there are a few steps there that will probably go a little bit faster, but I think we'll look back and see this as a massive triumph of science. The question is now, as we have the vaccines, now we move back to behavioral. So in the same way we screwed up behavioral things with masks, now it's going to be who's going to take the vaccine, which becomes another more sociological and behavioral problem. So the science part we're great at. It's the people part that we're not so good at.
Well, it speaks to several things. One is that we think that Bruce Springsteen is obviously a universal language for all age groups.
I'm glad.
Second, that we will continue to enjoy your wisdom on this. And thank you very, very much for being with us today. And I guess the final thing is, of course, that social sciences and that kind of the medical sciences absolutely need to work hand in glove. There can be no separation between them.